So what I'll try to do today is take you through precursor conditions, MGUS, monoclonal gammopathy of undetermined significance, and how patients who develop MGUS go on to develop progression into Waldenström or multiple myeloma. And can we, in the future, prevent that progression, screen the patients early, and potentially prevent them from having symptomatic disease in the future? Now, if we go back and think about it, every single patient who develops multiple myeloma or Waldenström would have had a precursor condition, an MGUS or a smoldering condition. And in many cases, these patients are asymptomatic, they don't even know they have it, or they're incidentally found by their primary care physician by having a small little high level of protein or something else that triggers the identification of the protein. And we usually just tell them, watch and wait, we will do nothing. And if you think about it, why would some patients progress into myeloma or Waldenström, while others will never progress in their lifetime? Their rate of progression would be even slower and slower. We need to understand better, is this because of a clonal evolution? Is this indeed what Esteban has just told you, of a true Darwinian evolution of clones that are competing with each other, and finally one of them will overcome the others and grow on to develop myeloma or Waldenström? Or is this some other factor, immune regulation, something else, inflammation of the microenvironment, a permissive microenvironment that allows suddenly those clones that are sitting around waiting to be initiated, they will be able to go on? And if you think about what has been done so far for clonal evolution, it's been done for active symptomatic disease, whether it's Waldenström or myeloma. And we've not really looked at the early stages of MGUS and smoldering. Now, there are very few samples that have been sequenced in MGUS and smoldering. And interestingly, those cases actually had all of the mutations that we think of in multiple myeloma. In fact, gene expression profiling has been done previously in MGUS and smoldering cases, and the cells looked exactly like the ones that you see in myeloma, which makes you think about, well, if the changes are already happening in MGUS, why are those patients not progressing on to develop myeloma or Waldenström? Now, recently, just a few months ago, Scott Carter from the Broad Institute and others have done a very interesting study where they took samples, multiple sequential samples from the same patients with Barrett's esophagus, which is a pre-malignant condition, and then the same patients when they developed esophageal cancer, and asked the question, is this truly a cell autonomous regulation, and what happens in those clones? And they found that indeed, what we used to think of as the notion of accumulation of multiple genetic instabilities and then finally oncogenic amplification may be true in some samples, but in others there was an early loss of p53, which again what Esteban told you earlier, and because of that there is so much genomic instability, and then you acquire all those oncogenic changes. So potentially our way of thinking that p53 may happen late may actually not be true, and it may actually be an early event that leads to that instability. But even with that, even if we think of p53, why would someone who has an early change of p53, and I see some of those patients with smoldering myeloma or even MGUS, will not progress on, and they have something like a hostile microenvironment that prevents it? And you start thinking that maybe indeed this is sort of the seed and soil phenomenon, the typical hypothesis that has been established for many, many years. And you can think that the same seeds, the same tumor cells that are present in different microenvironments may behave very differently. In one person who has an immune dysregulation or has aging changes or has inflammation changes will actually acquire enough clonal evolution and lead on to develop myeloma or Waldenström, while in a different person who has an intact immune system and a different microenvironment, that one will be extremely hostile and they will not progress on. So how do you ask this question, and how do you study a permissive microenvironment? You could think that indeed the old method that we used to think of the clonal evolution of one step after the other, now we think of it more of a Darwinian evolution. And finally, you can think of it as truly an interaction between the bone marrow niche or the cancer niche and the clones. And that interaction will allow certain dominant clones to go on and progress, while others may actually completely disappear. And understanding that interaction between the niche and the clone is critical for us to understand why would patients progress and others will not progress. So the first question we did, and to try and answer this question, is we asked, why would the stroma regulate the bone marrow or the clonal evolution in multiple myeloma as well as in Waldenström? And what are the spatial as well as temporal changes that occur with this clonal evolution? Is it all in one area in the bone marrow niche? Do cells interact with each other through exosomes or cytokines? Do you develop extramedullary disease because you have a certain clone that's dominant or because the changes in the microenvironment happen? And could you suddenly switch that and use it for your advantage? Can we develop therapies against the stromal microenvironment? We know now that the hot topic of immune regulation, and everyone is developing drugs for immune system, yet can we now develop other things for the stroma and endothelial cells to truly change the way we think of the bone marrow microenvironment? So the first study was done by two postdocs in my lab, Yuji Mishima and Michele Moschetta, where we tried to ask the question of clonal evolution within the context of the microenvironment. And here what they did is they labeled with fluorescent probes the cell line MM1S or other cell lines, and by putting several colors together and putting 2 or 3 different colors, you can actually have 15 subpopulations of the same cell line. So now you can have 15 different subclones that you can ask a question whether they're growing together or not. And in vitro, these cells will grow exactly the same way. They do not outcompete each other. So we call this the Rainbow Project, and it's a Trump world, so I hope that covers that. And what we asked afterwards is, now can we see what happens in vivo? Will they compete with each other in the bone marrow microenvironment, and will some of them be able to metastasize and go to the other host microenvironmental areas? So we implanted 2 bone chips, as you can see here, under the skin of the mice, and you put the cell lines, the rainbow cells, in there, and then you ask questions of competition within the plasmacytoma as well as competition at other sites, extramedullary sites, so the liver would be an extramedullary site, or other bone marrow sites, which would be metastasis, or circulating tumor cells. And you can start asking which clone will outcompete the other, and why would that happen? So here's an example of 2 mice where the primary sites, the primary plasmacytoma sites, show you that indeed all of the clones are growing at the same rate, and they're all competing with each other without having one dominant clone. While when you look at the metastatic tumor, it's a completely different story. One major dominant clone is taking over the whole metastatic site, and the rest of them are either disappearing or are at a very low level. And that tells you that there is a lack of entropy, there is a lack of heterogeneity in that area, and it looks exactly the same like when you see in metastatic cancers in solid tumor. The primary site has multiple clones, while the metastatic sites usually have one dominant clone. And you start asking the question, well, why is that dominant clone there? Is it because it has an expression or a gene change that gives it that dominance, that gives it that driver mutations potentially? Or is it because of the microenvironment that's permissive for that clone versus the others? And again, what we did is we asked the question of taking the primary cells from the first site, the primary site and the metastatic site, and did both RNA sequencing as well as exome sequencing to ask questions of gene expression as well as mutation changes. And you can see here with 2 cell lines with multiple mice that were tested, we had a signature that looked very similar. The metastatic sites were very similar compared to each other, and were very different than the primary site. And we were able to make a metastatic gene signature that actually, when you put it into gene set enrichment analysis for patient samples, it correlates very nicely with progression of patients from MGUS all the way to multiple myeloma. And indeed, you can see that also it correlates with survival of patients when you look at that gene signature in patients with multiple myeloma from prior studies of gene expression profiling. Now, if you go back to the same samples and ask questions, are there any driver mutations in those samples that will be present in the dominant clone? Again, it's very hard for you to acquire mutations that early because the timing of the transplant is only about 4 weeks or 6 weeks in the mice. So these have to be mutations that are present already there, and now they're allowing those clones to outgrow the others. And here you can see that indeed most of the clones were very similar between the primary and metastatic site, but there were some mutations that were indeed more present or more dominant in the metastatic site. And by taking those 2 signatures, the gene expression data as well as the mutation data, we developed a potential list of genes that could be important for metastasis in myeloma. And you can think of it as metastasis in Waldenström too. And here, trying to functionally validate those, we've done 2 things. Either we overexpress them by ORF, or we knock them out by the CRISPR-Cas9 model. And here you can see some of the early data that's ongoing right now of using the CRISPR-Cas9 in vivo validation of trying to knock out each gene and seeing if it is critical for the metastasis or not. Now, going on and trying to ask the question, well, indeed, are the tumor cells that are present in the bone marrow, all of them the same in the same sites? We do a bone marrow biopsy and we pick one area, yet if you had done a bone marrow biopsy in the other side, in the other pelvis area, you would have had completely different clones potentially. So are those clones talking to each other, and are they really important? And the other question is, well, how are we going to understand the whole system and all of the clonal changes if we're only picking one area and trying to understand it? So trying to ask the questions of spatial clonal heterogeneity and not just temporal, we started looking at the circulating tumor cells and asking if the circulating tumor cells will reflect the whole body and all of the clones that are present in the bone marrow. And also asking, are these specific clones capable of going out of the bone marrow because they're more dominant, they're more capable of exiting into the circulation and potentially metastasizing and going into liver or extramedullary sites. So the first thing we did is we collaborated with Jesus Miguel and Bruno Pavia from Spain, and here we've done whole exome sequencing of circulating tumor cells as well as bone marrow cells, myeloma cells, as well as T cells that are the germline. And you can see, interestingly, that almost all of the mutations were very similar between the circulating tumor cells and the bone marrow cells. In fact, 80% of them were overlapping, indicating that indeed in the future we may be able to use circulating tumor cells as a way for us to identify mutations and changes that occur in patients with myeloma or with Waldenström. So we can look at MYD88 or CXCR4 mutations in the peripheral blood instead of looking at it by bone marrow biopsies. Now, the other 20% were also interesting because you start asking the question, why are certain clones circulating in the blood and are not present in the same site of the bone marrow? And are these the ones that are capable to go on to develop extramedullary disease? Now, also, if you look at the copy number variations as well as the chromosomal alterations, indeed, we were able to see them all reflected in the circulating tumor cells. So again, potentially, the CTCs will be one of the methods that we use for prognosis of patients with myeloma or with Waldenström. And here you can actually use it sequentially in multiple times during therapy of the patient. So you can start with the newly diagnosed or with the MGUS and smoldering patients and follow that patient multiple times instead of just using one bone marrow biopsy at a certain time point. Now, the second question we asked is, well, can you look at extramedullary myeloma? And why would extramedullary cells stick to the liver or the skin or other areas and not just go to the bone marrow, which is the typical area where the myeloma cells would go? So to answer this question, Yuji Mishima developed a method to make the mice transparent. And this has been used previously in brain by a Japanese group. It's called the cubic method, where indeed you can make the whole tissue transparent. And now you can look at intracellular areas that are labeled by GFP or other fluorescent proteins. And here you can see that those mice that were made transparent, you can actually see the areas where there is the extramedullary clones in the liver or the bone marrow clones, which are the GFP labeled ones in the bone marrow. And by taking sequential transplantation of those two different clones, the ones that predominantly go to the liver and those that go to the bone marrow, and trying to understand why would they keep growing into the same areas, we separated them after 3 or 4 times of sequential transplantation and then did RNA sequencing on them and tried to look at what is the signature that differentiates an extramedullary disease from a bone marrow disease. And here, indeed, you can find that the most interesting signature was an epithelial mesenchymal transition signature. And you start thinking, well, myeloma cells are not epithelial cells. They're not supposed to have an EMT signature. And indeed, we have exactly the same transcription factors you have in breast cancer or other solid tumors. They upregulate the EMT signature, and that allows them to metastasize and disseminate exactly like solid tumors. And in fact, part of that EMT signature was a high expression of CXCR4. And CXCR4, as we know, is mutated in Waldenström. So the question was, is that part of that dissemination and metastasis? So we overexpressed, we indeed did a CXCR4 gain of function in the myeloma cell lines as well as Waldenström cell lines and tried to ask the question, will they now upregulate an EMT signature? And you can see here the phenotype changes completely and they start having pseudopodia and they start moving much faster, they disseminate much faster, and they actually adhere and invade much faster. But not only that, they actually upregulate all of their EMT signature. And if you take those cells in vivo and put them into the same mice models and try to ask the question, will they now metastasize and disseminate faster? The answer is yes. You have a faster progression into the other bone marrow sites and a faster dissemination to extramedullary disease. To further confirm this, we did an in vivo competition assay where now you put the CXCR4 gain-of-function cells as well as the scrambled control ones together and try to ask the question which one will outcompete to reach the extramedullary site. And indeed, we found again that the CXCR4 overexpressing cells will go much higher to the liver compared to the bone marrow, while the scrambled control will not go to the liver, indicating that potentially CXCR4 is a very critical regulator of extramedullary myeloma. Now, to then use that for our advantage, we said, well, CXCR4 is an easy target. You can actually use drugs to inhibit CXCR4 and think about that potentially as a future way to target extramedullary myeloma, which is one of the worst prognostic features we have in myeloma patients. So to confirm that, and actually the same thing for Waldenström, CXCR4 is mutated, overexpressed in Waldenström, and we can develop drugs, CXCR4 antibodies, or potentially small molecules that can prevent progression in Waldenström. Here we used a CXCR4 knockdown first to try and understand that indeed you can prevent that dissemination. And indeed you can see here by knockdown you have a significant change in the survival of the mice and a change in the bioluminescence, which is the tumor volume of those myeloma cells. Not only that, but when we used an antibody from Bristol Myers Squibb, which is a monoclonal specific anti-CXCR4 antibody, we were able to find indeed that it prevents dissemination and prevents extramedullary involvement and prevents multiple myeloma from progressing into those mice. So with that in mind, you can actually think that indeed all of those changes of clonal evolution are not just going on as in a cell autonomous pathway, but are truly dependent on a bone marrow niche that interacts with them, whether it's a stromal microenvironment or other microenvironmental cells. And then we started asking a question, well, what if there is a dominant clone in one area of the bone marrow, and will it interact with other clones? Will it go and educate or instigate the other slower growing clones so that they all can talk to each other, and it's not in one area of the bone marrow? This is not a contiguous method, but actually a dynamic method through the circulation. And we started asking questions, well, could exosomes be playing a part in that? Now, previously, we have shown a few years ago that the stroma in multiple myeloma patients is not just a benign stroma, but it actually secretes exosomes that go on and educate the tumor cells. And by doing that, they allow them to disseminate and metastasize and proliferate much faster. And the content of those exosomes was microRNAs that were very specific for malignant exosomes rather than normal exosomes. So Salomon Mani from our group asked the question, well, can we use peripheral circulating exosomes as potential biomarkers for patients during their progression from MGUS to myeloma, but also can we use them in the future as a therapeutic advantage? So think about it, if you have a patient with MGUS and they have the same mutations or same cytogenetics like another patient, can we use exosomes as a biomarker to tell us who will progress to myeloma and who will not? And the same for Waldenström. And here we took samples from about 300 patients from a French study prospective clinical trial of bortezomib and dexamethasone and took the supernatant, isolated the exosomes, as you can see by electron microscopy, and asked the question, what is their content? And first we did small RNA sequencing to try and differentiate normal exosomes from malignant exosomes, those that are present in patients with multiple myeloma. And indeed you can see by doing RNA sequencing, most of the changes that occur in exosomes are actually microRNAs. The others, SNO RNA, link RNA, all of those are a very minute population, and almost all of the RNA, small RNA inside the exosomes is actually microRNAs. And when you look at the signature of those microRNAs, one of them that showed up significantly lower in myeloma patients was LET7. Now, we know that LET7 is a critical regulator of B cell proliferation, of stem cell differentiation, but also of many cancer cells. And when we started to look at the Lin28-LET7 axis in myeloma, we found indeed that Lin28 may be activated in multiple myeloma patients. LET7 is suppressed in the tumor cells as well as in the exosomes that are circulating in the peripheral blood. Not only that, but it also regulates a very important pathway in multiple myeloma, which is actually the Achilles heel of myeloma, MYC and RAS. So here is one pathway that potentially could be targetable. We know that MYC and RAS are not targetable so far by drugs, yet you could use a LET7 mimic or a Lin28 inhibitor, and now you can actually regulate both MYC and RAS in myeloma. So to prove that, we used actually a LET7 locked nucleic acid that will upregulate LET7 in mice. And you can see indeed that the mice will have a longer survival, less tumor growth. But not only that, but you significantly inhibit both MYC and RAS in those mice when you take those cells ex vivo. Potentially now you can use that as a prognostic marker. The lower LET7, the worse the prognosis of the patients. But you can also use it as a therapeutic, precision medicine way. The patients who have low LET7, maybe you should give them a LET7 mimic or LET7 locked nucleic acid. Finally, in the last part, I'd like to talk about two different types of cells, the endothelial cells and the T cells, and how they regulate progression from MGUS to myeloma. So this is work by Michele Moschetta again, and we asked the question, well, for many years we've said angiogenesis is important in myeloma. In fact, Vince Raj Kumar always said that angiogenesis is one of the critical regulators of myeloma progression from MGUS to myeloma. Yet when we started using anti-angiogenic drugs in myeloma, none of them worked. We had a complete failure of anti-angiogenic drugs in myeloma. And the question was, why is that? Other than immunomodulators, which potentially can work as anti-angiogenic drugs, we're not sure why when we use an anti-angiogenic drug in myeloma, it doesn't work. And we said, well, maybe we're targeting the wrong timing of the population. Maybe by the time you have already symptomatic disease and already a high tumor burden, those myeloma cells are completely independent of their microenvironment with endothelial cells. And maybe if you go earlier at an MGUS or a smoldering stage, when those endothelial progenitor cells are there to allow the myeloma to progress and they are there to support it, then you can target them and now you can make a difference. So we looked at the VK-MYC mice, which actually progressed very slowly from an MGUS stage to a myeloma stage, and asked the question, do they have circulating endothelial progenitor cells, and do those happen early on or not? And indeed, you can see that EPCs, endothelial progenitor cells, will increase in the circulation in both patients and mice in the VK-MYC at an early time, even at the times of smoldering stage, and not at the late stages only. And when you look at those VK-MYC mice and try to actually change that EPC progression and use an ID1 and ID3 mouse model where now you prevent EPC mobilization and say, now can I prevent mobilization and change that survival of the mice, you find indeed that by using ID1, ID3 knockout mice, you can completely prevent progression of myeloma from an MGUS stage to a myeloma stage, and you have a longer survival in those mice. So again, by targeting the right population at the right time, by using an EPC inhibitor potentially, you can prevent myeloma progression. So to prove that, we use the VEGF-R2 inhibitor, which is a murine antibody, and try to ask the question using it early in the MGUS or smoldering stage in those VK-MYC mice versus late when they have already a high tumor burden, will that make a difference? And indeed, you can see here that there was a big survival difference in the mice that were treated early, but there was no difference when you treated them late, indicating that potentially anti-angiogenic agents, if we use them early in an MGUS or smoldering stage, they can prevent progression of myeloma, while when we use them at the late stages, like we have done in myeloma trials, they may not have any effect at all. Now, the final part is actually trying to look at other factors that could regulate progression. And this is work by Siobhan Glavi on the matrisome, which is the extracellular matrix. And here what she did is she did mass spectrometry in collaboration with Richard Hines at MIT and Dr. Antonio Palumbo in Italy. And we took all of that bone marrow extracellular matrix. So now we're not looking at the cells, but at the extracellular matrix and asking the question, are there changes in there that will allow this microenvironment to be permissive? And indeed, we found by looking at both mouse models and patient samples at multiple stages of disease that there were specific proteins that were dysregulated in malignant myeloma or in the bone marrow microenvironment of myeloma patients that could potentially be permissive or hostile for allowing progression or preventing progression of myeloma. And what we're trying to do now is you can now develop therapeutic agents to prevent that extracellular matrix from changing. You have now proteins that you can target as novel targeted areas in myeloma patients. Finally, the immune microenvironment. We cannot talk about the microenvironment without talking about the immune microenvironment. And I'm sure many of you have heard again and again about checkpoint inhibitors and about other cells. Now we're trying to understand what is changing in the immune microenvironment in an early stage of MGUS or smoldering, and can we now change that? Can we use the drugs that we're developing, immune checkpoint inhibitors, to prevent progression of patients? So here, this is work by Yawara Kawano, and what he did is, again, took the VK-MYC cells and tried to do an aspirate from those mice at different time points during progression. And indeed, by using CyTOF, which is a new method for you to look at multiple cells and multiple antigens at the same time, up to 30 antigens or more at the same time for the cells, we found that indeed that the Tregs were highly upregulated at an early time point. Not only that, they are changing in the bone marrow much earlier than when they change in the peripheral blood of those mice. And the same is true also for patients with myeloma as well as smoldering disease. And when you look at the surface checkpoint regulators in those Tregs, indeed you find an upregulation of PD-1, LAG3, TIM3, as well as OX40 in those cells, indicating that these could be targetable by all of those new therapeutic agents that we have as antibodies in our patients. Now, we also looked at the other immune cells, the NK cells, the T suppressors, and other cells, and tried to find indeed that what are the changes that are occurring in them. Now, to prove that indeed Tregs are essential for regulation of myeloma, what we did is we used another knockout mouse model, and here this is regulated by diphtheria toxin, so you can actually specifically knock out the Tregs at different time points with diphtheria toxin and ask the question, will that prevent progression of myeloma? And here you see this is the model where we used diphtheria toxin in the mice with VK-MYC, and you had a significant difference in the survival. In fact, those mice had no myeloma development when we used the diphtheria toxin, indicating that just depleting Tregs at an early time point may make a huge difference in our patients. And indeed, we're taking that, translating it into the clinic by developing either vaccine therapy or using PD-1 inhibitors and other immune checkpoint inhibitors in early time points for patients with smoldering myeloma as well as MGUS. So again, this is just showing you that we did RNA sequencing and tried to look at the different signatures that are in Tregs, and potentially one of them is the type 1 interferon signaling gene sets that we're now trying to confirm that indeed it regulates Tregs. So I hope that I took you really in the last 20 minutes through a journey of potentially understanding the microenvironment and really convincing you that indeed the bone marrow niche is not just a bystander, that not everything is about the cells. And indeed, we think that cancer is not just a cellular change, but truly an organ change. You need a lot of things changing in that organ. The bone marrow is an organ, and now you allow that progression of myeloma or Waldenström or other cancers. And the question is, how do you take that into the clinic? And in the last few years, actually thanks to an LLS core grant that we got, we asked the question, well, why are we waiting for patients to progress? We know all of those changes happen. We know the microenvironment will change and clonal evolution will change, yet we do nothing. We watch and wait those patients until they have symptomatic disease, and then we treat them. And you can think of a breast cancer patient, you see them and they have DCIS, you never tell this woman, oh, wait until you have metastatic lytic lesions in your bone and then I will treat you. You cure them early by doing an early therapeutic intervention. Yet in myeloma, maybe the only thing that we're doing wrong is maybe we're waiting too long until they have metastatic lytic lesions and then we treat them. So because of that, we developed a new clinic at Dana-Farber. We called it the Prevention of Progression Clinic, or Center for Prevention of Progression. And the whole idea is looking at all pre-malignant conditions in hematological malignancies, whether it's CLL, MDS, or myeloma, or Waldenström, and asking the question, why do certain patients with MGUS and smoldering progress and others don't? What are the changes that occur that are cell autonomous or non-cell autonomous, immune regulation, stroma, other changes? And how can we prevent that? How can we develop active therapeutic agents, whether it's vaccines, immune therapy, other agents that truly prevent progression of patients from smoldering disease to myeloma disease? We also developed a large tissue banking that's online now. We call it the P-Crowd, so that it's a crowdsourcing method. This is available for all your patients. They can just go online, download the consent, and send us samples so that we can have a large cohort and now try to understand mechanisms of clonal evolution in those patients. So with that, I hope that I took you through truly our journey with MGUS and progression into myeloma or Waldenström. I don't know if I answered the niche, the notch, and the nucleus, but I tried to answer the niche at least. And I'd like to thank, of course, many, many people, my lab members, my clinical team members, of course, Ken Anderson, Rob Soifer, Nikhil, and many others at Dana-Farber, our collaborators really from all over the world, our NIH support, Leukemia Lymphoma Society, and MMRF, and of course, our patients. Thank you.